Welcome to the deep dive. Today we're getting into a really common and often sort of unspoken issue that touches so many parts of life, erectile dysfunction, or ED.
Hmm.
Our guides for this are chapters from the very authoritative Rutherford's Vascular Surgery and Endovascular Therapy 10th edition.
A heavyweight source, definitely.
Right. And this isn't just, a dry medical thing. What's really fascinating is how ED connects to relationships, well-being, and it can even be like an early warning sign for other health problems.
That's a key point. It often is a sign of something bigger.
So our goal here is to pull out the crucial info, make it really clear, and highlight those surprising connections for you.
Exactly. It's easy to just think, oh, it's a problem down there, but the sources really emphasize it's often systemic. And the numbers, well, they're pretty stark.
How common are we talking?
We're looking at maybe 20 million men in the U.S. Globally, it's projected to hit something like 322 million by 2025.
Wow, that's huge.
It is. And interestingly, the rates are pretty similar across different ethnic groups, hovering around 20–24% for men over 40. The biggest jumps, though, are expected in developing nations.
Okay, so let's nail down the definition. Our sources say ED is the repeated inability to get or keep an erection firm enough for satisfying sex.
Right. Simple definition, but the impact?
Hmm.
That's significant.
Yeah, the text really talks about the negative hit to a person's well-being, their relationships, just their overall health, both physical and emotional.
Absolutely. And to really get why ED happens, we first need to understand how an erection normally works. It's surprisingly complex.
It's not just one thing, is it?
Not at all. It's this intricate dance between your psychology, nerves, hormones, blood vessels, and, crucially, the smooth muscle tissue in the penis.
Okay, so break that down. Anatomy first. The penis has these 3 cylinders of tissue, right? Spongy stuff that fills with blood.
Exactly. 2 corpora cavernosa on top,
Yep.
and the corpus spongiosum underneath, which also houses the urethra.
And it's all wrapped in this tough sheath, the tunica albuginea.
Yeah, think of it like a strong, flexible container. It provides the structure. Now, the blood flow, this is where our vascular source really shines, mostly comes from the internal pudendal artery, Okay. which then splits into smaller penile arteries, dorsal, cavernosal, bulbourethral. Sometimes there are accessory arteries, too.
And those cavernosal arteries lead to even smaller ones.
Right, the helicine arteries, these are the ones that directly open into those spongy spaces, the corpora cavernosa, filling them up.
And getting the blood out, just as important, I imagine.
Absolutely. Tiny veins, called venules, collect the blood, merging into larger, deep veins, eventually draining back toward the pelvis, into the prostatic or internal pudendal veins. There are superficial veins, too.
Okay, so that's the plumbing. But you mentioned nerves.
Critical. You've got somatic nerves for sensation and some muscle control.
Yeah.
And then the autonomic nervous system.
The automatic stuff.
Yeah, the parasympathetic branch is the go signal for erection,
Right.
and the sympathetic branch is more the stop signal for returning to flaccidity. The cavernous nerve is highlighted as a key player here.
Right. And the smooth muscle, how does that fit in?
It's fundamental. When the penis is flaccid, that muscle is contracted. That's controlled by the sympathetic system, what they call alpha-adrenergic control.
Keeps things quiet, basically.
Exactly. But then, with sexual stimulation, the parasympathetic system kicks in. It releases acetylcholine, which then triggers the release of nitric oxide, NO.
Ah, nitric oxide. That comes up a lot in vascular health.
It's the star player here.
Yeah.
NO sets off this chemical cascade, the NO-cGMP pathway, that tells the smooth muscle to relax.
And when it relaxes?
Blood rushes into those spongy chambers, they swell up, engorge. And here's the clever bit, that swelling physically squeezes shut the small veins that drain the blood away.
Like stepping on a hose.
Kind of. It traps the blood, maintaining the erection.
Yeah.
That's the veno-occlusive mechanism the source talks about. It's crucial.
Okay, makes sense. So how does it go back to flaccid?
That's when the sympathetic system releases norepinephrine. This makes the blood vessels and the smooth muscle contract again. So less blood comes in, and those drainage veins open up, blood flows out.
A very finely tuned system.
Extremely. And as you can imagine, if any part of this complex process gets disrupted, well, that can lead to ED.
Which leads us right into the causes. The textbook breaks them down, which is helpful. What are the main categories?
They list psychogenic, neurogenic, endocrinologic, that's hormones vasculogenic, which is blood vessel related, and drug-induced. But importantly, it's often not just one thing.
Right, there can be overlap.
Definitely.
Yeah.
Let's start with psychogenic. This is about psychological factors. It used to be thought of as the main cause, but now we know physical issues are often primary. Those psychogenic factors can certainly contribute or coexist.
So things like stress, anxiety.
Yeah, performance anxiety, relationship stress, depression, or just a general lack of arousal. Sometimes it's situational only with one partner, perhaps. A clue might be if erections happen at other times, like during sleep, or if it comes and goes with stress levels.
Okay. Then neurogenic. Problems with the nerves.
Exactly. Anywhere along the line, brain, spinal cord, or the peripheral nerves heading to the penis. Think conditions like stroke, Parkinson's, MS, spinal cord injury.
And surgery, too, right?
Yes, particularly pelvic surgery. The source specifically flags radical prostatectomy for prostate cancer because those crucial cavernous nerves can sometimes be damaged.
Right. What about hormones? Endocrinologic ED.
Testosterone is the big one people think of.
Yeah.
It's definitely important for libido and overall sexual function, but the direct link to ED itself isn't always simple.
Meaning?
Well, treating men with genuinely low testosterone hypogonadism can definitely improve erections. But for men with normal testosterone levels, giving them extra usually doesn't fix ED.
Interesting. Are other hormones involved?
Yes, the source mentions imbalances in thyroid hormones, prolactin, even estrogen can sometimes play a role.
Okay, now vasculogenic ED. Coming from a vascular surgery text, I imagine this is a big focus.
Huge. It's highlighted as a very, very common physical cause. Often it's down to atherosclerosis, hardening and narrowing of the arteries.
Just like in the heart or legs.
Precisely. It reduces blood flow into the penis and the pressure needed. Arterial injury can do it too. And then there are problems on the outflow side, issues with the veins not closing properly. Veno-occlusive dysfunction.
What causes that?
Could be abnormal venous channels or problems with that tunica albuginea casing, like in Peyronie's disease where scar tissue forms.
And this vascular link, it connects to broader health, doesn't it?
Absolutely critical point. Vasculogenic ED is strongly linked to cardiovascular disease, CVD. They share the exact same risk factors: high blood pressure, diabetes, high cholesterol, obesity, smoking.
So ED could be a warning sign.
A major one. The source emphasizes this. ED can actually predate heart attacks or strokes by several years. It can be an early indicator of systemic vascular problems.
Wow. The text mentions the artery size hypothesis.
Yeah, the idea is pretty straightforward. Atherosclerosis is body-wide, but the penile arteries are smaller than, say, coronary arteries. So blockages might show up symptomatically there first, like a smaller pipe getting clogged sooner.
Makes sense.
And it also ties into endothelial dysfunction, damage to the lining of the blood vessels. That lining produces the crucial nitric oxide. If it's damaged, NO production drops, and that directly impacts erections.
Okay. And the last category was drug-induced ED.
Right. And it's surprisingly common, maybe contributing to nearly a quarter of cases.
What kind of drugs?
Certain blood pressure meds, like thiazide diuretics and some older beta blockers, many antidepressants, especially the SSRIs, and drugs used to block testosterone, like those for prostate cancer treatment.
Okay, quite a list. So with all these potential causes, how do doctors figure out what's going on? How is ED assessed?
It starts, as always, with a thorough history and physical exam. The history needs to be detailed: medical background, sexual history, medications. Getting partner input can be really helpful too, if possible.
And approach matters, right?
Definitely. It needs to be non-judgmental. Using questionnaires like the IEF or SHIM can be a good way to open the conversation and get a baseline score.
And the physical exam, what are they looking for?
General health, signs of underlying conditions like vascular disease or hormonal issues, checking secondary sex characteristics. Then a careful genital exam, penis size, plaques, testicle size, and feel. Maybe a rectal exam depending on age.
And checking pulses and things.
Yes, because of that vascular link. Listening for carotid bruits, checking eye grounds for vessel changes, feeling pulses in the abdomen and legs.
What about lab tests?
Usually start with the basics: blood glucose, lipid panel for cholesterol, and a morning testosterone level.
Why morning?
Testosterone levels fluctuate. They're typically highest in the morning, so it gives the most accurate picture. And the source recommends that for men over 30 with likely organic ED, you should consider their increased CVD risk. Maybe order an ECG, check kidney function with creatinine. A cardiology referral might be needed if CVD seems likely.
So beyond the basics, are there specific vascular tests for the penis?
Yes, evaluating the actual blood flow. One common office test is intracavernosal injection, or ICI.
Injecting something to cause an erection.
Exactly, a drug like alprostadil. The doctor then assesses how firm the erection gets and how long it lasts. It mainly helps check that veno-occlusive mechanism and can be used to induce an erection for imaging.
What kind of imaging?
The gold standard non-invasive test is duplex ultrasonography of the penis, DDUS.
Ultrasound.
Right. Again, you induce an erection with an injection, then use ultrasound to measure blood flow velocities, how fast blood is flowing in during peak erection, that's the peak systolic velocity or PSV, and how much is leaking out when it should be trapped, and diastolic velocity or EDV.
And that tells you if it's an artery problem or a vein problem.
Generally, yes. Low PSV, say below 25-35 centimeters, suggests arterial insufficiency, not enough blood getting in. High EDV, maybe above 6 centimeters or a low resistive index, suggests veno-occlusive dysfunction. The veins aren't trapping blood properly. They also look for structural things, like Peyronie's plaques.
Are there more invasive tests?
There's selective internal pudendal angiography. It's like a heart cath, but for the penile arteries. Provides a detailed roadmap of the arteries.
When would you do that?
Usually only if considering arterial bypass surgery, mostly in younger men with trauma-related blockage. It's invasive and doesn't show function, just anatomy. There are older tests mentioned too, but DDUS is really the main vascular evaluation now.
Okay, so we know the causes, how it's diagnosed. What about treatment? What can actually be done?
This is where shared decision-making is key, as the source points out. Discussing all the options, pros, cons, tailored to the individual patient and partner.
Makes sense. Where do you usually start?
Lifestyle changes are really first line, especially if there's an underlying physical cause. Managing diabetes, high blood pressure, heart disease is critical.
And things like smoking, exercise.
Absolutely. Quitting smoking, losing weight, getting regular exercise all have evidence showing they can improve erectile function. And if psychological factors are strong, psychosexual therapy can be very beneficial, sometimes alongside medical treatments.
Okay. Then medications. The pills seem most common.
Right, the PDE5 inhibitors. Sildenafil was the first, then vardenafil, tadalafil, avanafil. They work by enhancing that nitric oxide pathway we talked about, boosting blood flow.
How well do they work?
Pretty well for many men. The source quotes around 70% success. The choice often depends on lifestyle. Tadalafil lasts longer, for instance, and is also used for prostate enlargement.
Side effects.
Usually mild headache, flushing, stuffy nose, heartburn. Some visual changes are possible, maybe more with sildenafil, vardenafil. The big don't is mixing them with nitrates used for chest pain that can cause a dangerous drop in blood pressure. And caution is needed with severe heart disease.
What if the pills don't work or aren't suitable?
Intracavernosal injection therapy, ICI, is a very effective next step, injecting medication directly into the penis.
Sounds daunting.
It can seem that way, but patients learn to do it themselves at home. Meds like alprapostil, often mixed with others like phentolamine and papaverine trimix or B-mix. Success rates are high, up to 90%, even when pills fail. The main risk is priapism. An erections last too long, usually more than 4 hours, and becomes painful. That's a medical emergency. It's not suitable for everyone, guys with clotting issues, unstable heart disease, maybe dexterity problems.
Are there other delivery methods?
There's an intraurethral suppository, MUSE, a tiny pellet of alprostadil inserted into the urethra opening. Less invasive than injections, but efficacy is more variable. Can cause penile pain or some bleeding.
And non-drug options, like pumps?
Yes, vacuum erection devices, or VEDs. A cylinder goes over the penis, a pump creates a vacuum, drawing blood in. Then a constriction band is slipped onto the base to keep the blood trapped.
How effective are those?
They can work quite well mechanically, but satisfaction isn't always as high. The erection feels different, less natural, and you have the device itself. And crucially, that band can't stay on more than 30 minutes.
Okay. What about surgery? You mentioned implants.
Penile implant surgery is really the gold standard surgical option for men who've failed other treatments or aren't candidates for, say, vascular repair.
What does it actually do?
It places devices inside the corpora cavernosa to create rigidity on demand. Doesn't interfere with sensation or ejaculation. Two main types: malleable rods, which are always semi-rigid, and inflatable implants, usually a 3-piece system with cylinders, a pump in the scrotum, and a fluid reservoir which allow for a more natural, flaccid state.
Satisfaction rates.
Generally very high for both patients and partners.
Yeah.
The biggest risk is infection, though rates have come down with better techniques and antibiotic coatings.
You also mentioned revascularization surgery earlier, bypassing blocked arteries.
Yes, penile revascularization. Potentially curative, but the source stresses it's only really successful in a very select group. Typically young men, isolated arterial blockage, usually from pelvic trauma, without widespread CVD or veno-occlusive problems.
So not a common procedure.
Not common, no. Usually involves connecting an artery from the abdomen, like the inferior epigastric, to the dorsal artery of the penis. Long-term data is a bit limited. Complications can include failure, hernias, penile shortening, sensation changes. Endovascular approaches like stenting have been tried too, but again, limited long-term data.
What about surgery for the vein problems, the veno-occlusive dysfunction?
Generally not recommended. The source says long-term results are poor because the leak is often a symptom of underlying smooth muscle damage, not just a simple plumbing issue. Maybe in rare cases of isolated traumatic venous leak in young men, a procedure called crural ligation might help, but evidence is limited.
So looking beyond current treatments, what's on the horizon? Any future directions mentioned?
Yeah, the textbook touches on a few promising areas. Restorative therapies are a big hope things, using platelet-rich plasma, PRP, stem cells, stromal vascular fraction. The idea is to actually repair or regenerate the damaged erectile tissue.
Still experimental, though.
Mostly, yes. Lots of research ongoing. Another area getting attention is low-intensity shockwave therapy, LEAT SWT,
Shock waves, how does that work?
applying low-energy acoustic waves to the penis. The theory is it stimulates blood vessel growth, boosts NO production, maybe helps nerve regeneration. Early trials look promising, especially for mild to moderate ED, but standard protocols still need more research.
Interesting. Anything else?
Endovascular stenting of penile arteries keeps being explored. Some potential shown in early studies, but figuring out patient selection and long-term durability are still challenges.
Okay. One last specific area the source covered was ED in men having other vascular surgery.
Right. Unsurprisingly, ED is really common in that population. Rates reported anywhere from like 39% up to 90% in some studies.
Yeah.
Men needing surgery for an abdominal aortic aneurysm and AAA often have significant ED even before the operation.
Does the surgery itself make it worse? Open versus endovascular?
It can. The picture's a bit mixed. Some studies suggest ED might decline similarly over time with both open and endovascular AAA repair, maybe just due to aging and underlying disease. But preserving blood flow through the internal iliac arteries during endovascular repair seems important. Embolizing those arteries definitely increases ED risks.
So something surgeons need to consider.
Absolutely. And the source makes a really important point. Surgeons should be discussing potential changes in erectile function with patients before these major vascular operations. Apparently, many patients later don't recall ever having that conversation.
Yeah, that communication piece seems vital throughout this whole topic.
Couldn't agree more. So, if we boil down this deep dive based on Rutherford's, ED is common, it has diverse causes, often linked tightly to cardiovascular health.
But there's a wide range of treatments.
Definitely, from lifestyle changes right through to advanced surgery. The crucial takeaway, though, is that ED isn't just, a quality of life issue, although it certainly is that. It can be a serious sign of underlying vascular disease.
Which makes talking to a healthcare professional absolutely key.
The vital first step.
Okay, that's a really clear summary. And it brings us to something for you, the listener, to really mull over. Given this undeniable link between erectile function and your heart and blood vessel health, what proactive steps could you take?
Yeah, think about supporting both your sexual well-being and your cardiovascular health. It's not just about treating symptoms when they pop up. It's about that bigger picture of long-term health.
If it really is a very important question to consider.
And if anything we've talked about today has struck a chord or raised questions for you, please remember the most important thing is starting that conversation. Talk to a healthcare professional.
Open communication is where it begins. From there, you can explore options, get a better understanding, and find personalized solutions.
Exactly. That's the path forward.